Good morning, everyone. My name is Francesca Rubulotta. I'm connecting from London, in the United Kingdom. It's the first time I've been invited to the IFAD, and this is the first virtual meeting. I would like to thank and compliment the organizers for embracing lots of principles that are very close to my heart. First, innovation, and second, equality and diversity. I will be talking about technology, which is a bit of a challenge when you have such a diverse and young audience. But probably I will limit my presentation to the technologies that we used at the bedside in my institution and in my co-author institution in Canada, in Italy. We found that the challenge of a pandemic required extra need of resources, which suddenly appear to be limited. And when I refer to resources, I'm not talking about exclusively equipment, but also referring to human resources. To the link at the bottom of the slide. At the beginning of the pandemic in March, big emphasis was given to the acquisition of mechanical ventilators. Authorities and governors spent a huge amount of money finding the ventilator potentially the best way to increase and to improve outcome of patients. Nevertheless, later on the pandemic, we realized that other equipment were needed, and especially that healthcare professionals at the front line were not trained, not protected, not enough to secure a good outcome from patients that were coming into our intensive care unit. To give you an idea of the spread of the pandemic in the United Kingdom, the date where the disease started in Italy was the 20th of February. The first case we isolated at Charing Cross Hospital was on the 9th of March. So there was no much difference at the beginning. And if you see the shape of the curve from the half of March until the middle of May, you can see that the peak was quite similar in most European countries. At that time, the government suggested that intensive care doctor had to care for a maximum of 60 severe critical ill patients. This obviously implied not a close review of every of them, but actually supervision of a lot of healthcare professionals that were redeployed into the intensive care, even without skills. It was a challenging time, and that's the reason why we will be talking about technologies to support work, daily work at the bedside. Where are we now? This is the shape of the first wave. As you see, then we got a period of let's say lower number of admissions to the hospital, and now this is the curve at the beginning of November with somewhere around here. What has changed between the first and the second waves? Obviously, we have developed education, so we have more knowledgeable people dealing with this disease. We have trust guidelines and technologies, which is the focus of my presentation today. Regarding education, I just want to highlight that simulation was crucial, and in this case, simulation did not provide exclusively skills, but also communication with other departments. In fact, the care that we provided was multidisciplinary, and the need of work together with colleagues from other departments was enhanced during our simulation scenarios. We have trust guidelines. This is a very busy slide, but the reason for this slide is to suggest that now we have pathways for patients arriving to our hospital, suggesting the treatment guidelines as well as the needed investigation. These guidelines are reviewed every 2 weeks by a treatment group that has at least 12 different specialties, or representative for at least 12 different specialties across Northwest London. What about technologies? This is the list of devices that we identify and we recommend for use in the settings where the pandemic is at the peak of the admission. First of all, the challenge of intubating patients suggests the need of having a fast, safe positioning of the endotracheal tube that protects also healthcare professionals. Several specialists have been infected at the beginning due to the spread of droplets during aerosol generating procedures. Therefore, the guidance suggested the need of the use of video laryngoscope. We also noticed that once we prone the patient, there was a tendency to develop severe edema, and this was another reason why we found extremely important to have video laryngoscope instead of traditional laryngoscopy. What about sedative drugs? At the beginning, we realized that that given that the increase of the demand for ICU beds, there was a shortage, an international shortage of drug supplies as well as equipment for providing those drugs in a traditional way. Therefore, we were forced to have new guidance, and this included the use of alternative way of providing sedative drugs as well as alternative medications. This is the first protocol that was implemented at Imperial College. You can see that, for instance, midazolam infusion, which is a standard of care, has been associated with alternatives such as the use of oral benzodiazepine or antipsychotic. The use of opioids, which are frequently given as an infusion, was suggested, was alternate with the use of fentanyl patches, and we started integrating inhaled sedatives as well as antihistaminic and drugs as dexmedetomidine and clonidine. In particular, dexmedetomidine has then proven being very beneficial during the period of weaning, which is prolonged in the COVID patients, and there are now case reports suggesting that dexmedetomidine can improve hypoxia as well as modulating the immune response of these patients. The general principle suggested also to have a daily reduction or even hold of sedation in these patients, which was not really the case during the first wave of the pandemic. And the reason being was that there was a lot of concern, once again, related to the safety of PPEs and to the spread of the disease among healthcare professionals. These are the guidance of the bigger society. For instance, the American Society of Anesthesia encouraged the use, as I mentioned before, of video laryngoscopy, while SNAC-DERO suggested that the patient had to be deeply sedated and paralyzed to avoid any response during the procedures, in particular intratracheal intubation. This is just an initial list, but it's much longer. And you can see that during the first wave, most of the attention was given on healthcare professional safety, even if later on we reconsidered this point. In particular, we did audit the performance of the intubation team that worked during the initial 3 months at Imperial College, and we noticed that this team was made by mainly more than 60% senior anesthetist, more than 30% senior consultant, and all of them were provided with necessary PPEs from the start, and none of our team contracted the disease with the given precaution. Therefore, we are now in the second wave looking to lighten our sedation. There's less concern, and I must point out that less of our patients have been intubated and deep sedated for a long period of time. But regardless the need of intubation, everyone that is admitted for the management of severe COVID-19 has to have a level of comfort. And this can be given very easily by professionals that work daily on the intensive care. It's more challenging when you redeployed not experts at the bedside. And therefore, we like to use the similarity anxiety with driving an aeroplane. The patient needs to take off with induction, they maintain the anesthetic period and land. During the maintenance time, majority of the people at the bedside were not necessarily anesthesiologists or trained ICU nurses. Therefore, we needed to use an autopilot, which could be initially taken by the operating theater ventilators that are not perfect, and we will talk about that during this presentation, but have new monitoring devices, or let's say old monitor devices that are not conventionally used in intensive care, such as entropy. Entropy and the BIS is a combination of electroencephalography and electromyography. They give us a simple number that can be read at the bedside by any operator, and has been available for more than 25 years. In fact, the use of BIS of entropy has been associated even with reduction of cost and better utilization of drugs, but has never been systematically used in intensive care because, as you can see from these slides, there's a lot of device around the patients, and the use of the machine is challenged by a high interference with other devices and the presence of a high number of artifacts. Therefore, it's challenging to have a good record or a good signal by the entropy and BIS spectrum, and it requires some level of training. Moreover, several patients during the pandemic have been prone, and the position of the BIS in a proning position is often challenging. Nevertheless, the use of the electroencephalographic and electromyographic monitoring at the bedside has been fundamental during shortage in the COVID-19. The initial recording has been done using only propofol infusion, but with some education, we know that even using infusion of midazolam or dexmedetomidine, we can have a signal that is somehow lower or higher, but is representative of the level of sedation of our patients. What about neuromuscular blockers? We use the Trainor 4. The Trainor 4 is provided by handle set machines that are very easy to use. The challenge with this machine is the control of the transmission of the disease, because they need to be sanitized in an appropriate manner before being used in between patients. And also it's very important to clarify the number of times this is used, because the reading is not continuous but need to be done at certain time, and sometimes when the workload is very high, it's forgotten. So I think a lot of work has been done in our institution to coordinate with the nursing staff the timing and the methods and the way to use this machine to provide a good neuromuscular blockage. Compared to the first wave, the patients are now less paralyzed, and as I mentioned before, we have been less concerned about spreading through droplets to healthcare professionals that are provided with appropriate PPE. What about facilitating appropriate notes and documentation? We suggested the need of having a paperless chart, everything at the bedside that is possible to remove from the bed space and to take away to the normal world can transmit the disease. Therefore, we collaborated with several stakeholders, and we managed very quickly in the first 3 months of the pandemic to eliminate any pen or papers around the bed space. Communication was quite challenging. We also changed the way we connected, moving from normal phone to different strategies. This is an example of the bed space before the pandemic, and now it's completely paperless. And all these calculators have been moved to a different way. What about testing the staff? This was a big challenge, and I don't want to spend much time on this part because now we all know the technology is moved on, but we recommend the use of bedside and point of care technology at the bedside. We also encourage to select perfect team that can be tested during the week in order to avoid the spread of the disease among healthcare professionals from patient to patient via healthcare professional. What about diagnostic? Point of care is crucial, and this includes testing. This includes thrombelastography, because we are all aware that severe COVID-19 patients have coagulopathies related to the disease itself. The D-dimer is a good method, but the thromboelastography is the best method at the bedside to understand really the degree of coagulopathy of these cases. Silvia Mangodi is another speaker in this conference. She has published very interesting job done in Pavia, where they use the ultrasound machine at the bedside. And the need of the ultrasound machine is for decision making, and also to store images and to provide those images in a separate space where experts can make decisions regarding, for instance, the ventilator setting. We are all familiar with the use of ultrasound machine, and there are now increasing evidence of what the forms of COVID-19 are, regardless the CT scan. Several of these patients were too unstable to be trusted for the CT scan, and also we limited transfer because, once again, the risk of infections. But we need to be aware also that during the first pandemic, several of them were ventilated in a way that caused frequent pneumothoraxes. This is a case of bilateral pneumothoraxes that could be monitored at the bedside without the need of repeating CT scans. We had cases of intracardiac thrombus, once again identified at the bedside, and the thrombus was treated and reduced and monitored without the need of transferring, moving the patients, only with one operator at the bedside. And this is a typical thrombelastogram of a case that has been admitted early on. And we are now familiar with these images, and we know how to treat them. What about the anesthetic machine? The anesthetic machine are not ideal for ventilation in intensive care unit. They need to be reset every day. They have a CO2 cartridge that needs to be changed with stopping the ventilation, which is not ideal for patients that need a specific recruitment maneuver and can worsen by disconnecting from the device. Nevertheless, the ICU machine have some benefits, like the entropy, as I said, the use of inhaling sedatives in a setting of limited resources, and definitely were needed at the beginning. This is just a fast overview on what has been used during the first wave. As I said, there have been significant changes. Technology has never been better promoted before in the intensive care. Even the knowledge of intensive care was not as common as before this pandemic. So I think it's been a terrible time, but has brought some clear benefit within our discipline. In this context, I want to point out that 70% of the staff at the bedside, at least in the United Kingdom, was represented by women. And these include nurses, healthcare professionals, and doctors. 16 billion hours unpaid working hour have been recorded in recent times, and this clearly has been brought by women in intensive care. I believe there still is needs of talk about equal opportunity and diverse opportunity, and this is the topic of the meeting that will be held in June 24-26 in Italy, in Catania, for really identify what the effect and the long-term consequences of this pandemic will be across all healthcare professionals, women and diverse population most of all. So if you have any interest, please use once again, the Twitter account that you see on these slides. If you have any question, please use my link. I hope that even if fast, I gave you an overview and tools to be used during the first wave. And with this, I wish all you to stay safe and enjoy the rest of this brilliant conference. Thank you very much for your attention.